Tracy, I'm just going to give it a little bit of time. I see we're at 14.
Yeah, I agree. We're not, it seems as though this group, they're usually in the first 5 minutes of several joins, so.
Mhm. 1 more minute. What do you think, Tracy?
I think, well, we can probably get started and then those that join can join the conversation,
Okay,
I think, just so we're not holding people up.
perfect. Well, welcome everyone to today's meeting. Hope you all had a wonderful holiday. Um, we're just going to start off with our agenda. So I'm just going to do a quick opening, the usual housekeeping. Today's meeting, we're just going to go through to start the summary of our provider meeting that we had. So I just wanted to give you a quick summary of that. And then we're going to discuss the extension and then go through with some of the recommendations. You all should have the summary of the last meeting. I'm just going to, summarize a little bit of it, but you have it. And you also should have the questions that we asked for today. So you should have had that, which was sent out to you yesterday. So I just wanted to do a brief recap of the provider meeting that happened on November 19th. We'll review the provider recommendations once everyone has had a chance to speak. That's in regards to the questions for today and your recommendations. But I did want to touch on the issues and questions that were raised by the providers. Concerns were raised about the difficulty for smaller and rural agencies that they would face in meeting the new safety and staffing expectations. Many lack the funding, staff, and capacity to implement additional support measures, such as peering staff or providing ongoing safety devices. It was also noted that the grant funding for implementing these measures is currently limited to Medicaid the Medicaid population, which doesn't capture the full scope of home care patients. We discussed finding and identifying a more long-term sustainable funding option. We talked at length about the intake data requirements to be collected. As we've learned over the past few months, this information is not always readily available or willingly shared by referral sources. The requirements also leave an incomplete picture, as the judicial branch website only accounts for in-state offenses and does not account for the criminal history outside of CT, juvenile offenses, or other potential safety concerns, such as a history of substance use. We discussed the recommendation from the law enforcement representatives to contact local or state police. We agreed that home health care agencies do not have the hours, days, or weeks to wait for information before entering a home, and trying to do so would lead to delay in care. While the information collected may help change practice and enhance safety, the collection process is simply too challenging and time-consuming. Concerns were also raised about the data collection process placing a singular burden on home care agencies. As I mentioned during the meeting, the burden also raises questions about whether these new statutory requirements even fit correctly within the scope of home health care services. I also made a point, along with everyone else, that requiring nurses and aides to make this assessment that are traditionally made by a team of individuals, including physicians and doctors. These assessments, which essentially involve prescribing the type of support or level of care a patient may need, is well outside of the scope and supportive secondary role of home health care nurses. The committee members also raised significant concerns about all of the data collected potentially being used to discriminate against patients by denying care to those who we deemed unsafe. We also discussed the potential privacy concerns and how it would be important to notify individuals in a home that data was being collected. We also discussed how agencies might still face citations or fines from DPH and OSHA, even when when the appropriate safety measures are in place and followed in events like fires or assaults. Regarding the training requirements, we discussed what would be the best and most effective way to deliver the training to create environments where home health care workers feel comfortable and are willing to share their experiences. Finally, we noted the fast approaching deadline for the report and discussed a possible extension. Tracy reached out to Senator Anwar and Rep. McCarthy Vahey to request an extension to February 1, 2025. Tracy, do you want to give us any update on any of that, or?
We did get the approval for an extension, and they want the report before the end of January. So not February 1, but before the end of January is when they want the report. And then the only other thing, Sasa, I'm not sure, I was listening, but did you talk about the crime report? I think you talked about the judicial branch being only only in state, but the crime report issues, that we found that the report just isn't a report that gives us we talked a lot on our regular larger work group meeting as well, that the crime report really doesn't give us any really valuable information as far as hot spots in certain areas of certain neighborhoods, et cetera. It just gives you general information about crime in the towns and cities, the municipalities. And I think Sasa, you talked also about the issues for other disciplines, not just home health, that also go into homes, EMS, et cetera. So I think that was one of the issues that was raised.
Thank you. Anything else to add, Tracy, before we get started?
I don't believe so. I think, we had a really good meeting a couple of weeks ago, and we discussed a lot of the concerns, and we did come up with some good recommendations. So we're curious to hear from you today on all the things that you've heard so far on the larger groups and then this list of concerns, what you feel might be priorities. So Sasa, you have the questions. You want to give the guidelines for how we're going to do this today?
Yes. So, thanks, Tracy. So we're gonna go around to each committee member for you to share your top three recommendations based on your respective industry on what you've heard. In order to keep the time, each committee member will have 3 minutes to present. We won't get into questions. I'll just keep moving on to the next committee member. And so we just want to be respectful of everyone's time and mindful that we only have a few meetings left to get to the end of January. So to get going, I'm going to start with Chris from Masters.
Thank you, Sasa. Chris Pankratz with Masters in Home Care. And I have my three areas are really looking for a shared responsibility with the compliance requirements from the state. So having, since the current law mandates risk assessments, I think we need to offer, or they should offer a system to process the patient information and deliver risk scores directly to agencies. That would make it objective and consistent across all agencies. And with that, I think referral sources need to be required to disclose all relevant information they have on a patient so that we have a complete picture and some sort of centralized state system as part of that state responsibility. I think the existing processes as they are should really be optional because of all the challenges that this group has outlined. Agencies really shouldn't be required to independently gather and verify data beyond our capacities and abilities. So that's number one. I think, number two is really prioritizing our staff safety, which, looking at it from this perspective that, we should continue to advocate for state mandated safety training that's designed and provided by the state. So again, consistency in content and delivery, and having that training address many of the topics we've looked at and many agencies have already implemented, but violence prevention, incident response, and personal safety strategies. And the last section is looking at best practices over mandates and funding. So we really we really should look at and encourage agencies to adopt best practices as we figure out what's best for our industry and all the different provider types and all the different areas of the state. I think, having legislation that has mandates in it is always, doesn't always work because it's not going to fit agencies of all sizes and types. And as with anything, the grant funding is a little too limited in scope. So I think expanding that to really anyone providing home-based care beyond just the Medicaid population and have it be sustainable. So there's future funding available for all agencies, regardless of size and where your services may be delivered. Thank you.
Thanks, Chris. Next, we have Terry from Aviana. You're on mute.
Thanks. I know. Thanks, Sasa. Others have said it and we'll say it, but it's, we think it's important to implement processes that improve worker safety and at the same time carefully review and potentially amend requirements that, although well-intended, do not meaningfully improve safety, but do create obstacles to care and could negatively impact access for families. To that end, some echo Chris's comments, but we would support reviewing and revising the data and intake collection requirements, including the necessity that referral sources share information that's available, consideration of the creation of a state repository for the specified information so that there's one place to look for providers. Also support state provided training. And finally, the funding concept, including things like eliminating the subsequent visit rate for home health visits, implementing an acuity risk-based add-on rate, expanding the grant eligibility, and similar things to provide support for the appropriate and necessary requirements to improve safety. Thanks.
Thank you. Next, we have Barbara Pierce.
Karen Enders is going to go first.
Okay, Karen.
Hi, Tracy. Hi, Sasa. Thank you. So some of the topics include, as you know, I just still don't agree that, you know, hospices can be mandated in this. It's just not going to the cost if we're required for any reason to do 2 staff members. It's impractical, and like others, we're not able to. As important as safety is, it's just not going to work with 2 staff members on a regular basis. I think the Department of Public Health should come up with some guidelines, but not regulatory, due to the fact that it's going to be very difficult to meet some of those regulations if it requires those background checks. We don't have the time in hospice. You know, hospice needs to be out same day, often. So having that requirement, and depending on the referral source, will not guarantee that we are getting the background checks and the information that is necessary for any individual home, due to, as stated in several other meetings, the amount of people that will be coming in and out of any home. And so the staff, a process, not a mandate, and DPH coming up with some guidelines for agencies that will be effective and working as a team to collaborate and ensure safety. And perhaps one of those would be, if we're going to be wearing alarms or what have you, some funding towards that from the state of Connecticut.
Thanks, Karen.
Thank you.
Barbara?
Well, obviously, I agree with Karen. I think it's really important not only to put the cost on us, and also not to put the burden on us of what's adequate and may not work. So I think it should be tied to the nurses' licenses. As I've said, the state has now waived their license fees, but they still license every nurse of every level. And I think that they should tie the training to the license, so that when people change agencies and whatever, they're not, it's not the agency's job every time. And it's that way there's a lot of turnover in our industry. And if we start training people, we're going to have to train every 2 weeks. So tying it to the nurse's own license or the aide's own license or whatever seems to me to make a lot of sense, and let the state decide what the right training is and let the state run it. Because I think that putting in something into it is to say that they're going to pay for it and give us the money for non-Medicaid people. It's just not going to happen. Medicare's already said they're not contributing. So and insurance companies are worse than Medicare. So I think it has to be something that the state takes on if the state thinks it's going to work.
Thanks, Barbara. Jen?
Hi, Sasa, thank you. So I agree with everything that's been said thus far. One of my top priorities would be that the state does develop some best practices for us rather than mandates, but considering those best practices need to be applied to all different areas, populations, rural settings. To tag on to what Karen said, to have 2 staff accompany on visits may not always be physically possible, because of we have some serious challenges here in the northeast corner with nursing shortage. So that's important. What's very important to me is the inadequacy of the referral information that we're often getting on many patients. I work in a hospital system, and I've been part of training as a highly reliable organization, in HRO 2.0. And one of those core concepts is the concept of giving a safe and appropriate handoff across the care settings. And that is not happening. And it places a huge burden on us as home health and hospice providers to basically go to the ends of the earth to dig, appropriate clinical information. But now we're also being asked to look into this additional safety information with background checks and checking registries and so forth. So it's placing a large burden on us. And then my third, it is about the data collection. If we can somehow streamline that, make it a central repository of information that is more easily accessible. We have one intake nurse, and she's doing a lot of work on these background checks. We want to make sure our staff are very safe. We will do just about anything for our staff to be safe. But what I find is that we're spending a lot of time on this, and the patients may not necessarily be getting the clinical attention that they need and deserve. So we're doing a lot with very few resources. So those are my challenges and my wishes for this work group.
Thanks, Jen. Thank you. Is Lauren here?
I don't see her, Sasa.
Okay. Eric?
I don't see
Oh,
Eric either.
okay. All right. So I'm just gonna go forward. No, Eric. Okay. We have Stephen Magro.
All right. I would start with the safety training. It should definitely be standardized through the state. I would also just add that there are other entities that can provide this training, qualified entities, including union training and upgrading funds. So possible grants for entities that work with workers to provide the safety training. I think, but a standardized state curriculum is essential to that. I would also add that the referral info on patients needs to be, more robust. And I think also more better collection of data, not just about the individuals, but about violence against workers, against the caregivers. That's an important, that's an important piece of information, and I think we need more highly developed data about that to help us understand, the scope of the problem. The last thing that I'll add is in this industry, there's a deprofessionalization of the work. I think a professionalization of the work is important. So creating a career ladder for these workers, including certifications for, that can result from trainings, is absolutely essential. The churn of people through this industry is unhelpful for all of these issues, and we really need to have these workers be treated as the professionals that they are, and have them have a career ladder, something to look forward to, and to just improve their lives and the lives of the people they care for. That's my top three. Thanks.
Thanks, Stephen. Next we have Sierra Gadsby.
Yo, Dad. Wow. I think someone just died in front of the crowd. Look at this video that Sam just sent. He was driving by. Look.
David, if you could mute. Sarah?
Hi. Yes, I think I echo a lot of what other individuals have already stated. The priority being obviously staff safety and really looking at staff training in regards to violence prevention and community safety. These type of outside providers could be able to do a standardized evidence-based training model. Risk assessment, again, looking at what the evidence-based risk assessment process is and having a look at a standardized form. And again, agree with that there really can't be mandates in the legislative process just because of the onus falling on different agencies and how hard it is to fund those.
Thanks, Sarah. Next, we have Tyler.
Owning that I'm kind of the outsider here as running a community health center where we have community support staff, I would suggest that the safety training is a top area of focus. And although I like the idea of tying it to the license, because we have many non-licensed people who are doing this home service delivery, that instead having the statewide curriculum, and maybe it's good for 2 years or whatever, so that that could handle as people go back and forth from different locations. That's one. The requirements that somehow an agency like mine are not held to, that you all are held to, seems ridiculously onerous, leading to my two topics. One of going back to the other person's suggestion recently about the scope of the problem. I think we, taking nothing away from the tragedy that occurred, it feels like moving to requirements without enough of a study of what percentage of time are our staff actually at risk, to me feels premature. So more we'll look into the scope, and then moving more to best practices to ensure that we have safety as opposed to these legislative mandates that again, I just think are too onerous for makes me happy that we're not held to them, and it seems unfair that you all are.
Thanks, Tyler. Benjamin?
I don't see Benjamin.
Okay. Karen Buckley.
Hi there. So I apologize because I missed the last meeting. I was traveling, but I think on behalf of the hospitals, we continue to have some concerns about ensuring appropriate access to care for patients of all backgrounds, all the diversity of patients. Obviously, we're also very concerned about staff in that in that arena. And we just want to ensure that we're really looking at, are we, as a state, the collective we, putting into place things that could delay access to care, hinder access to care, or in some cases just completely make access to care impossible. And I think there are some ways to do that. Some folks have talked about, are there ways to increase rates to provide funding to provide a higher level or additional number of staff to go out to provide that care? Is there funding available for additional safety grants in a more flexible way? I think, there is part of this mix. We're very focused perhaps on the patient themselves. But as I understand, at least based on my experience in home care, it's not necessarily just the patient themselves, right? So we could be providing information about a patient, but there are others in the household or family that may be a different risk, right? So are we providing information to our employees that lends itself to them thinking there's really no issue when there could be an issue? I just am a little concerned about the real information that the real protection and safety efforts that need to be provided to staff. And I think at some level, we're really focused on gathering all this information, putting all this information in a database, which I'm not really sure is in the best interest of developing patient care and or the employees that are going out and providing that care. So I just would encourage us to, I think a little bit like what Tyler was talking about, really looking at what are the things that we think we can put in place to protect employees who are providing really essential care in the community while maintaining access to care for all patients.
Thanks, Karen. Next, we have Kim. Hi, Kim.
Hi, everybody. Thank you. I appreciate a lot of the comments that are being said, and I also apologize for having missed that last meeting. It's really clear from all these meetings that we all have the same goal in the end, to be able to provide good, equitable, accessible patient care and keep our staff safe, who's ever going into that environment. That being said, I think the greatest challenge is the balance of that and how it does move forward. I think training has been our number one focus. And although I appreciate the sentiment of adding something to licensing, nurses practice in all specialty areas and practice settings across the board. So unless something was specifically written for home care services or something like that, I think you'd have very different levels of training that would be done for very different places, whether you're in a clinic, in a hospital, in an ambulatory surgical center, or what have you. I also believe that training goes much farther beyond general, information about personal safety, identifying risks, finding an exit, positioning yourself. As we heard the testimony, in the meetings about whether it's, someone walked in behind you or a patient's son puts a gun on the table and rolls it around. I mean, it could be anything. So our nurses need to be able not only to, have the knowledge, they need to know specifically, what could be the potential risks. I come from the injury prevention world in early childhood, and we go with a framework that you can predict and prevent incidences, right? And the list of things you guys shared about things that have happened and that I've heard from nurses, if nurses know that any things these could happen and they have a plan and they know what they're supposed to do, that's what they need. They'll go in and do it. Right? They want to take care of the patient. But that comes down to a very more individualized than just some generic training smacked onto a nursing license. So I'm really not in favor of the idea of just having a total generic training. There needs to be some very individualized stuff that happens in a home visiting situation. And I think the training needs practice. I think it needs assertiveness. Our healthcare providers are caregivers. Folks want to take care of their patients. They understand that they need them, and they will put themselves in their safety out in front of that need, if so needed. And so they need that assertiveness training and need to have the words, the skills, the practice to do it. The tools and resources, I think, are another huge thing. I've heard you guys talk about the cost. I think we need to put together some cost and forecasting and say, listen, this is what it would cost if we need an escort, if we need some kind of notification system. What is it? And if we fully staffed and funded that, or we can't within the constraints of what we have, how many patients are not going to be cared for? And put it in some real cost numbers, because the burden shouldn't be on the provider going in the home that the system can't help them be safe. It shouldn't be that now they're sacrificing their safety because the system can't help them be safe. So I think some sort of a balance, or being able to quantify what that means and what it looks like, so that the providers can have access to the tools and resources they need to be safe, is critical. And, to the points that, like, we don't know how many times this is happening or where it's happening, I think continuing to collect that information and so we can be data driven is going to continue to be critical. And that feeds into my last point about ensuring that we have policies and practices that promote a culture of safety, and that there isn't pressure put on providers that, listen, you didn't go into that home, or you waited, now you had to see 3 people and you didn't. And that's why you're going in there. And that's why people are making a choice to make a visit or go in and put their safety at risk. I think that there needs to be some sort of a best practice, or a debriefing, or something like that, that allows for, real time, treated like professionals, allowing people to be professional and talk about what their situations are and be part of the problem solving process. the folks that came on and shared about their experiences, I bet they have 10,000 ideas about how they can, improve safety and what can be done and what do other people need. And I think they should be engaged and tapped for that work. So that, I guess those are my top. I guess we get 3, so those are my top 3.
Thanks, Kim. Next, we have Josh Clark.
Don't see him.
Don't see him. Okay, next we have John Brady.
Yeah, hi, everybody. I'm staying off camera because my internet's so poor at home, but so I've heard a lot of good things. I think I'd like to emphasize a few things. One is the training. It's really critical. And as far as whether or not to tie it to a license, I mean, there are probably a way to do this. I get the fact that if somebody is working at one agency and they go to another agency within the same year, it doesn't make sense that if the training is the same across the board, that they'd have to repeat it. But certainly something that, said you had to take the training somewhere every so often. And Stephen's right, there are other groups that can provide that. As far as risk assessment, which is also, I think, really, really important. I think it sounds like there's a lot of challenges to that, including costs, but also including just some of the systems, like with the police and the reports we get. But also, I thought I heard someone say something about the handoffs. So I think those are the types of things that just need to be improved. We got to have risk assessments, or else this doesn't work at all. So I think we need to work on that kind of stuff and doing that. And then just a word of caution about mandates or regulations. I know nobody likes mandates and regulations, but the fact of the matter is that if they're not there, then things don't get done. And what happens is one agency will do it the right way. They will do best practices because they just have leadership that will do that, or they're financially able to do that, or both. And another agency might not. And then it's not a level playing field, and it's also not safe for patients. So I think those are the 3 things that I wanted to bring up.
Thanks, John. Next, we have Julianne Giard. Sorry.
Good afternoon. Have given some thought to what we might be able to contribute from DEMIS, and I would focus on the area of violence risk assessment. It is something that we have to do in the course of the services and that we provide. So we do have some risk assessments that we used, and also some standardized ones that are available in the field, and also trainers. We know of some trainers that could train in the area of risk assessment, all in the theme of best practices, I would say, or recommend. And I think that's pretty much it.
Thank you. Next, we have Barbara Cass. Barbara, did you have anything to add?
You might have stepped away for a minute.
We'll move on to Angel Quiros.
Let's see, Angel.
Here. Okay. Next, we'll go on to Anna Carabin.
Hi, good afternoon. I think my top 3 would be, one would also be standardizing some sort of safety training across the agencies. A centralized system across multiple agencies that will provide information related to the clients and any potential safety concerns, and maybe even tying in those hotspot areas of towns that police may have that information. And then also expanding the scope of the funding, if we do have extra funding, to other sister agencies that are also beyond home health agencies that are also going into homes and providing in-home care. And then also, again, expanding the items that would be available for purchase as well.
Thanks, Anna. Barbara, did you have anything to add? Yes.
Thank you, Sasa. No, I think I'm going to abstain from making any recommendations, but I do appreciate everyone's comments. They're very relevant to the conversation, but thank you.
Thank you. David? I'm gonna move on and see if David comes back. Auden? No. Rihanna?
She's there. We can't hear her.
Oh, Auden.
She's trying.
Okay.
Yeah, we're not hearing you, Judge. Yeah. Might want to check your speakers. Yeah, I don't know if they might have sent out a call-in number too, if that's easier for you to be able to share. We'll come back to you.
Okay. And David?
Yeah.
Rihanna, were you here representing the commissioner?
I am, and I have Chief of Staff Ron Cotta here with me as well. We appreciate being a part of this workforce, but we would defer to the healthcare providers who are actually, in the field and doing the job for recommendations. I know we gave feedback a few weeks back about suggestions along with some of the municipalities, the sergeant, lieutenant that we're on. So other than that, I think we would defer to those that are boots on the ground in the field.
Okay, thank you. All right, I didn't hear from David as yet. Did I forget anyone? Did I leave anyone off before I move on to Tracy and myself? Okay, Tracy?
Oh, thank you, Sasa. Thank you to this work group. A lot of real think tank discussion, thought-provoking, trying to really help us figure out what is obvious before all of us, that it's an extremely challenging task for this work group to figure out how to do the best we can in the most cost-effective way, but also in the most efficient way so that we can optimize care, access to care, not discriminate against, any particular population or type of patient that could get referred to us. So a big challenge, but I agree with many of the comments that have been put forward that some type of standardized training to include workplace violence prevention, situational awareness specific to community. I know Kim Sander talked about, we could have training to all the different care settings, and yes, you can, but we're really looking specifically at the home and community-based space for this work group. So it's important for us to make sure that if we put training forward, that it's something that we can really apply to the type of work that we do in the community. So standardized training developed truly, by experts, not just looking to us, but maybe the providers along with some of the stakeholders on this work group that have so much experience. I know Julianne was talking about some of the standard that you have for risk assessments and different trainings, et cetera. And I think, bringing the expertise to the table to create something that would really work across the board for the home and community-based space. And then, I agree that tying it to a license or a certification, a CNA, et cetera, is a really tough ask. And that if there's a way for us to track it, and I'm thinking of DSS creating the elder abuse training that is now required for all mandated reporters. there's not really a tracking system for that other than, say, DPH comes into the home, it comes into an agency to evaluate your agency through survey process. That can be the question, show us your staff that took this course. You know, we would need to do something that would hopefully mitigate the duplication, which is, I think Sasa brought that forward initially, you know, going from one agency to another, making sure that we're not asking people to get trained every single time they change their jobs. Although reinforced training could be a good thing, having a standard training and having some kind of a tracking piece, but not necessarily tying it to the license, but putting the burden on that staff member to make sure that they get that training. Next, I would, so after training, I would put in the best practices next. No mandates, but best practices. And Jen talked about HRO, high reliability organizations, you know, safety committees at your agencies, QAPI or quality assurance, process improvement, looking at risk stratification, looking at your near misses at your actual events, what happened, try to review what can we do to mitigate future, trying just to do the best we can to have some common best practices, and our association would be happy to work on creating such best practices that could be used as potential standard across the board. And then the funding, to me, has to be in place. The funding would need to be for multiple purposes. It needs to be to create this repository that people are talking about if we're going to have an easy lookup process. We need to have a way to create that so that the agencies aren't looking in all different areas for the information. Have that in there, have that with the standardized risk tool, not to give us detailed information about the client, more so give us a risk level score so that we know what we're going into and we can hopefully provide proper interventions to help mitigate that risk, whether it be through the training for the staff or through devices or a possible escort pairing, et cetera. That funding needs to happen. We did talk about the subsequent visit and the add-ons. Those are two areas that I think we should certainly be able to request, because subsequent visits, and I know this might be going over the head of some, but we tried to explain it early on. Subsequent visits are half of the rate that we get for a visit once we go into a setting that we've already been into for that day. So we get half the rate, even if the case could still be high risk, we get half the rate, which means even fewer resources that we're able to provide to be able to go in and see that person the second time, or someone living in the same setting a second, you know, another time for that day. So the subsequent visit, an add-on rate that we hopefully would like to bring back, and just giving us funding that's not specific to Medicaid to help fund all of the resources that we need to be able to provide safe care in the community. So centralized repository training and funding. Thank you.
Thanks, Tracy. And so I think I'm the last one, so I'll quickly go and then I'll get back to your question, Barbara. All right, thanks, Tracy. Over the past several months, as I've considered my recommendations, I've looked at it from the lens of a home healthcare agency representative and also as a nurse practitioner, psychiatric behavioral health nurse practitioner who can prescribe the need for home care services and also can prescribe the level of care that's recommended to keep someone safe and those around them. I look at a lot of the data that's needed to be collected, and to me, it seems logical that the prescribing provider who's may set forth the level of care that someone might need. So if someone's going to need 2 people in the home at the time of a visit, I think that's something that a prescriber should decide. And at that point, there should be reimbursement to match, similar to when a prescription is written versus taking something over the counter. A prescribed level of care should be honored by our current payer system. Currently, everything ties to the insurance and reimbursement for us in home health and for all medical providers, to be honest. So if we're going to send 2 people, who's prescribing that? Who should make the decision to prescribe that level of care? And who should cover the cost of that level of care that is required to keep someone at home safely and to also deliver the best outcomes? So to say that a home healthcare agency is responsible for assessing the risk, identifying what care needs to be provided, and to provide their own resources accordingly to us is outside of the scope of a home care agency right now. Now, when referring to providers saying that the level of risk for a patient or the type of staff, the care, as I said, that they may need, currently that's prescribed. If it's going to be wound care, we get a prescription. This is what's needed. If it's a medication, if it's IM, if it's PO, if it's twice a day, that is prescribed by the referrer, the physician, the nurse practitioner, or whoever is ordering care. And when a patient is being referred to any level of care, the prescriber would also let us know regarding what the care needs. I would also let the agency know what level of care is needed, the medical conditions, and other information relevant to providing competent care. So if there was a history of violence that was already known, a risk of violence based on the diagnosis or based on other substances that the individual might be using, which would put others at risk, I would make sure that that information is in the referral and prescribe the appropriate level of care. And as we've discussed, there's an echo. And as we've discussed with this working group, understanding the patient's risk, concerns, and needs are all critical to providing care safely. Therefore, it makes sense that the information related to safety should be collected also by providers who have a better understanding of the patient and who can communicate medical to medical the patient's specific needs and keeping both the patient and the home care workers safe. The information collected, it gets us so far though. So we also need to ensure that home care agencies have the support, training, resources, and whatever else is needed to deliver care safely. We can do this by, one thing I'm thinking of, establishing a way for home care agencies to have access to internal ACT teams as needed. So when something is going on, the agency has the resources, just like other providers, to deploy ACT team as needed in a timely fashion. And that can be done for patients who are high risk, and the agency can do so in real time. We also need to look at modifying, as Tracy said earlier, and other providers, modifying the reimbursement structure for care delivered in multi-generational homes and congregate settings. Oftentimes, home care agencies see individuals in those environments that have a unique risk and other complexities that demand more than a one-to-one staff to patient ratio. But as Tracy said, in those environments, we are paid a subsequent rate. Modifying the reimbursement structure will help agencies address the challenges that workers face in these settings and allocate the necessary supports to be able to do so. Creating a standardized training program for home healthcare workers. This training should include behavioral health certification for behavioral health nurses. So nurses who are doing the psychiatric in-home nursing should have a certification by an accredited body, similar to the way I had to be certified to get my APR and license. I think similar to what we're all saying, tying the education, the certification, and the training to the license upon renewal is necessary. So the behavioral health lead primary care nurse should be certified to deliver behavioral health care. And we should also have safety training similar to the EMS workers and others who directly work with high-risk individuals by equipping all workers with these skills so that we can empower our workers to navigate the diverse and unpredictable environments that they encounter. And to wrap up, the bottom line is that home health care worker safety is a complex and multifaceted issue. We've seen through the presentations that we will never have all the information we need to properly and fully assess all of the potential safety and violence risks that may exist. Even if we could, the nurses and healthcare workers, as nurses and healthcare workers, we don't have the luxury to pick and choose the ideal patients and circumstances. Our job is to provide quality medical care to the patients that need it, regardless of their background, circumstance, or zip code. Therefore, what we need most is to train and support, the training and support to do our job safely. In the same way, the agency representatives that spoke throughout these meetings, that we've heard from them saying that they've received training, they have the support to do their jobs. The home healthcare sector needs similar protections for similar risk. I hope that the recommendations that we finalize over the next 2 months are equitable and ensure that the home healthcare workers and home healthcare aides are safe no matter where they are. Thank you. Barbara, you had a question?
Yeah, I had mentioned this in the comments about at the last meeting, but what about the fact that in hospice, you often get people at the end who are coming from out of state. Are we going to be, or from other countries, are we going to be exempted from checking people? I mean, there's no practical way to do that. We don't even know where they're coming from in some cases. That's one question I had. Secondly, I wondered, is there a bypass if the person is actively dying? Because we're not going to get there in time. If it's a weekend, if it's a night, is there something that's equivalent to SIA? And thirdly, are we going to be protected from the CMS rule that we not discriminate in our care if we say no to a patient because we don't have a second person and they're in an area and they're an underserved population?
But Barbara, it also, actively dying is one thing, but somebody can come on today and not be actively dying, and by 7 o'clock tonight, there's a big change and they're actively dying.
No, I agree, but I guess my point is, if time is of the, what makes time of the essence? In other words, if we don't bring services to the family, are we protected from that? If they're, if it looks like it was discriminatory, if, you know, it looks like they think we could have checked them out in that amount of time, and what do we do if the people come from far away? I guess I just don't see the parallels. I mean, someone earlier said, well, you know, I guess the nurses do different things, but I mean, hospice is fundamentally different from a lot of kinds of home health care, and I don't understand how we're going to be exempt from rules put on us by federal agencies. So I just wonder how we get around, how the state will get around that by passing a law if the law countermands what we've been told by Medicare.
Thanks, Barbara. Anyone else? Did you have anything to add before we?
Judge Grogans, were you able to get sound?
Not sure. I didn't want to interrupt.
Yes.
Can you hear me?
Yes.
Oh, good. I think that no, I think that my role is more to help you, assist you with information, and if you had any questions about the judicial system. So I think that, you know, I'm going to confine myself to that role if that's okay with you.
Okay. Thank you. And Tracy, we've made it through every provider. We did so in 1 hour.
Imagine that.
Yeah. So the 3 minutes, it worked. And our goal now is, so the next meeting is on Tuesday, December 17th. The same time, right, Tracy?
2:30, yeah.
2:30. So our goal now is to then narrow down our top priorities, and we can take the time to do so now, or is it then that we gather, have the time to think, digest all that's happened, get the summaries from Peter and get everything over to everyone, and then circulate back around at the next meeting with our top priorities? Or because we have an hour.
So, yeah, so I may tap into some of the experts on the group, and I'm probably gonna call out Karen Buckley and Kim. Is Kim still on? Sander? She might have stepped away. Oh, there she is. Because I'm assuming that both of you and others too have probably been on many work groups, legislatively appointed work groups, and I've been on one prior. So the one that I was on, we did process similar to this, came up with the top, priorities of recommendations, but also a report that would be comprehensive as to the process that we went through on the work group, and the listing of issues and concerns that arose through the process. And then even if we come up with top recommendations, that we've also listed some of the other issues that were brought forward to make sure that they're included in the report. So does that sound appropriate to those that have been on work groups before? And are we leaving anything out regarding the process that we should be following?
So I think that sounds right. I mean, typically you talk about, here's the issue, here's the concerns, here are the problems identified, whether or not you have potential solutions for them. And then you either can do your top recommendations, or you can do recommendations. I've seen it done as kind of short, medium, and long-term recommendations. Chances are you're not going to get all of your recommendations done in 1 year, so you might want to kind of pick the most pressing ones first, or other groups prioritize them.
Yeah, for example, I think we've heard a lot about potential repository standard training. Those can't happen immediately. They have to go through process. So you're recommending, and that makes sense. If there's some short low-hanging fruit that we want to make sure that we're putting into a short-term recommendation and then plan it out. This work group does terminate once the report is submitted. So that makes that's a good recommendation to follow. Who else? Anybody else have anything they want to help us with in this regard?
Tracy, one of the things I was thinking about with this is if you set it up kind of like a project management, where you have your different topics and, where we stand. And I agree with Kim where some of the costs perhaps could be included in this project, management program, so that we can present all that information, because the cost, we truly don't have an idea, but I have a feeling it could be quite costly, especially when we're talking 2 staff members. That'll put Jen and us probably out of business if we were doing 2 at a time. We're not the size of Yale and Hartford and those bigger ones. That's just a thought.
Yeah, I'm not sure that that's under our auspices as much as maybe we make the recommendation for the funding to cover costs, and then a study. I don't know how that would work.
Yeah, I mean, because are we allowed to push back? This group will, once it's submitted, the group is no longer, but are we allowed to push back and say, oh, whoa, wait, I mean, they could be putting huge costs onto us. We have no say.
Well, that would be part of the legislative process too.
Yeah,
Yeah,
so there'll
Be
be,
put forward.
there'll be an opportunity for folks to weigh in on the legislative process, but I think Karen's point is well taken, that that is a concern that would be highlighted as a concern I would expect within the report, right? Much like, our concern of, does this delay access to care? Does this deny care to folks, right? That's a significant concern. I would expect that would be included. I know folks have shared those concerns, but one other avenue, Tracy, is you can ask folks if they aren't comfortable sharing this, to send those concerns into you to ensure that they're included. And Karen, one of your concerns could be, you're going to require somebody to do something that you didn't fund, an unfunded mandate, right? That could be one of the concerns outlined in the report, that any efforts made, I'm making it up, for training or otherwise, would be funded by the state, right? That could be one of the principles or things included in the report.
And we did send out, Peter sent it out yesterday, the list of issues and concerns that were brought forward. So we do ask that you review those concerns and offer any additional, or offer your comments to those concerns. If there's something that we've missed, please make sure that you're sending that to us so that we can incorporate. But I really think that it might be helpful, and let me know what other people think, that Sasa and I kind of try to put a draft together with all of the issues and concerns that you additionally send in to us besides what we went over today, and then also list the priorities that everybody brought forward today. And maybe that is our starting point at the next meeting, to make sure that we're not missing anything and make sure everybody's voice is heard. And there were several people today that were not present at the meeting, so making sure that they have the information and can offer comments and suggestions as well. Kim?
Yeah, I love that, Tracy, and not to put pressure on you and Sasa, but if we could get it, with so that I can share it with some of my subject matter experts. I mean, I have a lot of people telling me things and sharing things with me. And so it would just be great to just even have 24 hours to be able to send it around and try and get some feedback from them as well. I know you said you got an extension, so I don't know if there's going to be another meeting past the December 17th or whatever date you said it would be. But I also think, you said this group is no more, and that may be something that we incorporate
That we
into
recommend.
yeah. I mean, I just think it's so incredibly helpful to hear everyone's perspective and what the challenges are. And it's just so valuable to the process. And I think it helps us, even though, we're not going to agree on everything, and but we all really have the same end result in mind. And it's just kind of, how do we get there? And I also think the data piece, proposing, as I think it was Karen who said, like, map out, a plan, but to really, if there is data that we need to continue to collect so that we are continuing to form, have some data-driven decision-making moving forward that can help us ensure that we're not doing work that's not helping, and that, how much is it needed and where is it really needed, and what are we really finding? Like, what can be simple enough, but just leaving space for that moving forward. I think I hear that it's a huge burden on everyone, the data and the way things are happening right now. So just thinking about how could we scale that back, but still have what we need, because things are evolving so quickly out in the world every single day that it feels like it just is an important space to continue to ensure it's shared so broadly across systems.
Part of the 2419 Public Act did require DPH to set up the portal for reporting of workplace violence events, and it was defined within the law as to what was supposed to be reported, and I believe it starts March 1st. DPH just announced it 2 weeks ago, I believe, is when they actually put out the information on how to submit. Prior to 2419, home health and hospice providers were required to just send in an annual report on workplace violence events and no detail behind any of it. So very difficult to collect any data that's substantial. So, you know, I don't know if that's something that we look at, but again, there was also in the law DSS having the ability to set up enhancement payments for agencies that timely report events. So that would be for the Medicaid only. So that goes back to funding for Medicaid only and not for all, which can certainly impact access to care.
Tracy,
Barbara, yes. Oh, I was just gonna ask a question, Barbara. Go
I was
ahead,
just going to
Karen.
say one thing, Tracy. I think one of the things in the report we need to think about is there are folks who may be interested in the outcome of what these recommendations are that are not included at this table. And that will influence things. So we should just keep that in mind, right? There are a bunch of patient groups that really are not, patient advocacy groups that are not represented here at the table, that will have, even without asking them, very differing opinions on what the outcome should be.
When we talked about that on the issues and concerns too, the privacy issues. If we're looking into patients, do they realize we're looking up all their information and then
putting it all in one database where
yeah.
lots of
Yeah.
people can search it. Yep, I suspect
And I
that will
guess
be.
to your point too, Karen, is if we do, I think Kim made the recommendation, if we do make one recommendation to extend this work group to continue to look at the information and make any further recommendations, are the right people at the table? Are there people missing that should be here that we just didn't think about? So that's something probably to ponder. But Barbara Cass, I was going to ask you, trying to think I can't remember who mentioned it before. But maybe you can share with the group if Medicare has standards, we have conditions of participation with Medicare. We have state regulations for our license. So how does DPH go into an agency and evaluate whether an agency is compliant when one standard may be very different from another standard? I think that was mentioned prior. So if Medicare has a more stringent standard than the state or vice versa, how does DPH review that? I want to make sure everybody understands that.
So I'm not sure I understand the question, Tracy. You want me to describe? So certainly the most stringent standard will always apply, whether it's at the state level or the federal level. And depending on the conditions of participation across the sector, in some cases, the federal conditions are more stringent, but there are many cases where the state requirement is more stringent. So when the survey team goes in, they are looking at compliance with both state and federal regulations. Connecticut, I think we are very fortunate in Connecticut in that we have state regulations as it relates to home health. Many states do not license or have a set of regulations on the state side for home health. We're very fortunate in Connecticut in that we do. And the regulations, both on the state side and on the federal side for home health, are very comprehensive. And they are on the list for revision. And I suspect as we move forward with looking at healthcare worker safety, there may be references to that in the future. I did want to react though to your comment about the data that we collect at DPH regarding episodes of workplace violence, and we can help get you that data if it is going to be helpful for the report. I do want to just indicate that it is an aggregate number. In the back, we have some level of detail, but for the most part, a facility, an entity is only required to report the aggregate number, the episodes of an instance of workplace violence as it's defined. So it's not going to provide a large level of detail, but at least it gives you some level of the scope of the issue, which may be helpful. And then, of course, the new portal that's being developed for next year is going to be much more comprehensive, but not going to help for the purposes of this.
Right, but it would put, the new portal will eventually be collecting on type of event.
Yes.
So it can be categorized.
Yes.
Thanks, Barbara. To echo something I heard Tyler say earlier, and it's something that's been on my mind. Barbara, as the data, or when we report incidents of violence in a workplace environment or healthcare environment to DPH, going back to what Karen said about individuals and their rights and making sure that as we send the data in, because it's not going to capture what happened prior to the incident. I'm not sure if we're capturing that. So when we call in that this individual was violent or did something that is worth reporting to DPH, and now there's a ping or there's something assigned to that individual, not just in the DPH way, but if we have this big cloud of information about addresses or individuals that's a concern, if we're not putting or collecting data on what occurred up to the incident, how are we assigning this label to individuals who need healthcare? So are we then going to say, look at the incident, okay, this person was without meds for 10 days, and we know that if you needed your Risperdal or your Haldol and the nurse missed 10 times, now next week you had a situation in the home. If your insurance didn't prescribe your Risperdal, there isn't a pharmacy near. Is it a female that's in the home versus did the doctor prescribe for a male to be, how are we going to make sure we paint the picture to where the data we're collecting is giving us the qualitative information and not just the quantity? How are we going to make sure that we paint the full picture so that we can address the way we deliver care? We can also say, well, we found that if someone missed their meds due to snowstorms, missed the meds because who knows, whatever the reason is, how then can we make sure that we're collecting data which paints the accurate picture and not just label the individual on the other side of who then might have become psychotic and did something that they wouldn't have done had the treatment been a certain way? How do we then evaluate that side? So I want to make sure that as we collect data and as we ping addresses and locations, that we're also pinging where the system had gaps and how it led to this prior to just saying, we know that this person is a one-to-one now, but why? And what should we be careful of along the way in delivering their care? So I'm hoping that if we are going to collect, that we're collecting the incident around what happened before, what led, that day, and then what happens afterwards to get that individual back on track if there was a way to do so. And I think that's the real, the goal should be, because that ultimately will improve the delivery of care and the health outcomes for individuals and their families who really need it. Like they're counting on us to get it together. So I'm hoping that we can figure that out also along the way. So Tyler, that switch to think this what is going on, what happened, and do we have a real issue in home care where individuals are here that are a risk, or do we have a big picture that we need to look at how to close those gaps and get, you know, the right care at the right time as much as possible?
I think, Sasa, what you're describing, though, is incredibly important, but it's also trying to strike that balance between who has access to the information and what patient protected information that we're sharing. But your comments are so critical to the incident where there may have been some discontrol. So it's finding that sweet spot and balance that is going to be the challenge. But again, I do want to underscore how important it is.
And does that fall into perhaps some of our potential recommendations for best practices, Sasa, with, you know, say we have safety committees at each agency, and your internal investigation of an incident, and you know, you're going to include all the background prior, and that none of that's going to go to the state in the portal. The state in the portal is just going to be an incident occurred, and you know, I don't even think that it's any kind of names or anything. It's just this incident occurred. So it would be internal, I think, where we would do our QAPI process to evaluate what happened and how we might have been able to avoid it, or now looking at the future, how we can mitigate it so it doesn't happen again. And if we then look and say, oh, geez, we constantly are having a problem with getting medications from this pharmacy on time for these patients, we find a trend, then that's something that we can manage internally, I would think. But part of best practice is another support. Kim?
I was going the same place, Tracy, that like, I would hope that the agencies have those councils and they're doing root cause analysis and using that information to inform safety practices moving forward. I know that sometimes on paper that says that's being happened. So it'd be really great to know that it was really being happened. I don't know how you do that part. But I think with all of us here, I definitely feel such a commitment to figuring out how to do this right. That it would be that I would hope that place, because what you're talking about is it's what I think about in nurse safety, actually everywhere we go, that when you have the incident, it's the tip of the iceberg. There were 10,000 things that led to that incident. So if you're only addressing the incident, you're missing everything else. And that's where you create bias and barriers and stuff, is just looking at that tip of the iceberg. So I think it's an incredibly important point to stress in our report, that full understanding of incidences, and that root cause analysis and how that information is being used for continuous quality improvement. How is that being evaluated and ensured it's being done in a regular, systematic way? I appreciate that. I feel like we keep talking about the nursing process, just to those nurses out there.
Thank you. Anyone else, or are we near? It's almost 4. If there's, Tracy, I think if there's nothing else, or then we're
good
until the next. So
the next meeting, we're going to try to get a draft of something to you that has the issues, concerns, and all of the recommendations that were brought forward today. And try to get it to you ahead of time so you have some time to really look through it. You have actually the issues that we presented at the beginning of today's meeting, so maybe just add to that if you have things you want to add. And then we'll try to get that to you in advance of the next meeting, so you have enough time to review the priorities and see if there's anything else you might recommend. That meeting is Tuesday, December 17th, 2:30. And then we did look at the calendar for January. I know Kim mentioned, if we're having another meeting, the January meeting, I believe, was that the 7th?
Yes.
Tuesday, the 7th. When hopefully we can have a pretty good draft put together by then. And then we'll see from there. Was that good for everybody? Okay. So we will see you all on the 17th of December. And thank you very much. Great meeting and discussion today. Really appreciate all of the experts at the table or on the screen, however you want to say it.